Warning. The following is supplementary information for my patients. Much of the information has been simplified significantly for ease of understanding. In this video, I will be talking about shared care prescribing. Before I start, could I ask you to familiarise yourself with the what about logical fallacy? Right, now that you've done that, let's get started. So, first of all, it's important to understand what shared care prescribing is all about. Certain medications are only considered to be suitable for prescription by the correct specialists. This is usually because the medication or the diagnosis is associated with a higher level of risk or uncertainty. Common examples are medications which suppress the immune system, such as methotrexate or sulfasalazine, or medications for ADHD. However, it also includes several other medications, for instance certain kinds of bone strengthening medications, which can only be prescribed under very specific circumstances. However, some difficulty arises because these medications are prescribed fairly commonly, and they're usually prescribed on a fairly long-term basis. What this means is it's something of a challenge for the specialist to prescribe every single prescription for this medication themselves. And this is where shared care prescribing comes into play. Shared care allows the delegation of certain parts of prescribing to be passed on to a general practitioner. In essence, this is a three-way prescription between the consultant, the patient, and the GP. The shared care contract is entirely optional, and it can be rejected, refused, or cancelled by any of the three parties at any point in time and for any reason. So, what does shared care prescribing actually entail? What I'll do is I'll run through the roles and the responsibilities of the three key parties. Though before I start, it's important to remember that there's actually technically a fourth party who is the pharmacist, and a pharmacist has the right to reject or refuse any medication which they feel is inappropriate. Firstly, the role of the consultant. The role of the consultant is to assess the patient and recommend, start and stabilise any shared care medications themselves. It's expected that they'll explain the shared care contract to the patient and take overall responsibility for the clinical care for that particular condition. They should then recommend an individualised monitoring and follow-up plan for that particular patient and communicate it to both the patient and the GP. They should also be available for any medication problems, queries, or for any dose adjustments which might be needed. They're also expected to review the patient regularly and at least once a year as an absolute minimum. Next is the patient responsibilities. Firstly, and probably most importantly, it's expected that the patient will participate proactively with the shared care. What this means is attending all booked review appointments and proactively booking, as well as attending for all necessary monitoring. It's also expected that the patient will use the medication safely and appropriately as recommended by the specialist. The final party in this agreement is the general practitioner. There's an expectation that the GP will perform any required monitoring as needed, though it is important to remember that the responsibility for booking these appointments rests with the patient. The GP then has a responsibility to check that all monitoring has occurred and that all monitoring results are okay before issuing every single prescription. And, by extension, if the monitoring hasn't occurred or the follow-up hasn't occurred or the results are outside of the range, to immediately reject the prescription completely. Of course, if the results are abnormal, we would also be expected to relay these to the consultant to get their advice about what to do next. And this is generally true even if we know the answer, because as I said earlier, all of the medications are ultimately the responsibility of the consultant. This leads on to a further important point. Shared care prescribing is a sharing agreement, and what that means is if any of the parties drop out of the agreement, then the agreement immediately ends. We frequently run into this problem when consultants attempt to discharge patients with the expectation that shared care prescribing continue. Obviously, if they drop out of the agreement, we can't continue to share care with them, and that means that shared care prescribing
must stop immediately.
Saying that, the agreement can be stopped by any of the three parties at any point in time for any reason whatsoever. In my experience, one of the more common reasons for this to occur is patients not booking their follow-up appointments or attending for their follow-up appointments at the right time. And though we will try and remind people from time to time, if we have to do it repeatedly, then this does become a safety issue, and it is a good reason for us to stop shared care prescribing. However, usually everything goes really well, everybody pulls their weight and does their part, and this is a really good and effective way for us to prescribe medications which we wouldn't usually be able to prescribe for patients. Bye for now.